Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're diving into a true cardiac emergency, ST elevation myocardial infarction, or STEMI. If there's one thing that requires quick thinking and immediate action in medicine, it's this. Whether you're prepping for the PANS or PANRE, or managing patients in the clinic or ER, today's episode will break down how to recognize, diagnose, and treat STEMI efficiently. Let's get started. Beginning with some basic pathophysiology, a STEMI occurs when there is a complete occlusion of a coronary artery, leading to transmural infarction, meaning the infarction affects the full thickness of the myocardium. This blockage is typically due to plaque rupture and thrombus formation in an atherosclerotic coronary artery. The major problem is that without immediate intervention, the affected myocardium becomes necrotic, leading to irreversible cardiac damage, heart failure, arrhythmias, and/or death. That's why early recognition and intervention are critical. Now, who do ST elevation MIs affect? STEMIs most commonly affect older patients with coronary artery disease. Risk factors include hypertension, hyperlipidemia, diabetes, smoking, older age, especially over 65, men are at higher risk than women, history of prior coronary artery disease, myocardial infarction, or revascularization, cocaine use, which can cause coronary vasospasm and mimic an acute coronary syndrome. When it comes to ethnicity, Blacks, Hispanics, and Southeast Asians are at increased risk. A positive family history of coronary artery disease, especially if at a young age, and obesity, poor diet, and sedentary lifestyle. It's crucial to recognize high-risk patients early because time is myocardium. Now, how about the clinical presentation? A STEMI patient might present like this, with crushing substernal chest pain or discomfort that radiates to the left shoulder, jaw, or arm, maybe at rest or with minimal exertion, more commonly in early morning. Diaphoresis, nausea, vomiting, shortness of breath, or syncope may accompany the chest discomfort or may be the only symptom. Some patients describe a feeling of impending doom. And nitroglycerin has little effect, and even opioids may not relieve the pain. Now be careful, not all patients have textbook symptoms. Patients with diabetes, women, and the elderly can have atypical presentations, like dyspnea, weakness, or abdominal pain instead of classic chest pain. The initial physical exam should focus on findings that permit rapid triage and aid in immediate diagnosis and management. You want to think first of all about your ABCs, so think about patient's responsiveness, airway, breathing, and circulation. Examine for evidence of systemic hypoperfusion, so check for hypotension, tachycardia, impaired cognition, or cool, clammy, pale, ashen skin. You also want to evaluate for evidence of heart failure, so check for jugular venous distension, new or worsening pulmonary crackles, hypotension, tachycardia, a new S3 gallop, or a new or worsening mitral regurgitation murmur. And it's important to note that bradycardia can be a sign of right coronary artery occlusion, because remember, the right coronary artery supplies the SA and AV nodes. Now let's talk about the diagnosis. When a STEMI is suspected, time is myocardium, so the first steps are a 12-lead ECG within 10 minutes of arrival. You want to look for ST segment elevations in at least 2 contiguous leads. Reciprocal ST depressions can further support the diagnosis. And also keep in mind that a new left bundle branch block with associated symptoms is a STEMI until proven otherwise. You're also going to order cardiac biomarkers, especially the troponin. Troponin is a structural protein in the heart that is released as a result of myocardial injury. It helps confirm myocardial infarction, but shouldn't delay treatment if you already have ST elevation by electrocardiogram. Additional labs that you'll want to order to assess associated risks or triggering factors and prognosis are going to be your CBC, your complete metabolic panel, lipids, A1C, a B natriuretic peptide, coagulation studies, and toxicology testing if needed. And additional imaging as indicated, such as a chest x-ray to rule out other causes like aortic dissection or pneumothorax. Now, some key electrocardiogram STEMI patterns to remember are the following. An anterior MI will show ST elevations in V1 to V4, and that will indicate a left anterior descending occlusion. An inferior MI will show ST elevations in leads 2, 3, and AVF, and that will indicate a right coronary artery occlusion. A lateral MI will show ST elevation in leads 1, AVL, V5, and V6, and that will indicate occlusion of the left circumflex or the left anterior descending. And for a posterior MI, you would see ST depression in leads V1 to V3. If you see this, this should prompt you to check the posterior leads, which are V7 to V9. And if you see ST elevation here, then that would indicate right coronary artery or left circumflex occlusion. Now let's move on to the management. STEMI management is all about opening the occluded coronary artery as soon as possible. A reperfusion strategy should be chosen within minutes of arrival. The two main strategies are the following. Number 1, the primary goal is to have primary percutaneous coronary intervention, which is PCI, within 90 minutes of emergency department arrival. If not a PCI-capable center, then can patient be transferred to another facility and have a PCI within 120 minutes? And number 2 is fibrinolytic therapy. If PCI isn't available within 120 minutes, patient has no contraindication to fibrinolytics, and symptoms have been present less than 12 hours, then fibrinolytic therapy is indicated. In addition, you want to initiate medical treatment within 20 minutes. And so here you want to think of MONA-B. MONA, M-O-N-A-B. So MONA stands for M for morphine, O for oxygen, N for nitroglycerin, A for aspirin, and B for beta blocker. And so let's go through these. Morphine is given only if pain persists after nitroglycerin. Oxygen is given if oxygen saturation is less than 94%. Sublingual nitroglycerin is given to patients presenting with ischemic chest pain, followed by IV nitroglycerin in patients with persistent pain after 3 sublingual nitroglycerin tablets, hypertension, or heart failure. Now, nitrates must be used with caution or avoided in settings in which hypotension is likely or could result in serious hemodynamic decompensation, such as right ventricular infarction or severe aortic stenosis. In addition, nitrates are contraindicated in patients who have taken a phosphodiesterase inhibitor for erectile dysfunction within the previous 24 hours. Aspirin is the A in MONA-B, and this is 325 milligrams chewed. And the beta blocker is the B in MONA-B, and this is given to reduce myocardial oxygen demand and should be given within 24 hours in patients without any contraindications. And although not part of the mnemonic, you also want to give a high-intensity statin as early as possible. Another treatment that is also part of the regular management is antiplatelet and anticoagulant therapy, but this is determined by the type of reperfusion strategy chosen. Now, regarding prevention. Preventing further events is key in long-term management. This includes lifestyle changes like smoking cessation, regular exercise, and heart-healthy diet. Managing hypertension, diabetes, and hyperlipidemia are also imperative. And you want to recommend adherence to the post-MI medication regimen, which would include the high-intensity statin, a beta blocker, an ACE inhibitor or an ARB, and dual antiplatelet therapy with aspirin and a P2Y12 receptor blocker, which is usually clopidogrel. Now, before getting to our practice questions, here are a few clinical pearls. Number 1, time is myocardium. Every minute counts. Number 2, STEMI patients need urgent percutaneous coronary intervention or fibrinolysis. Don't delay reperfusion. Number 3, check for right ventricular infarction before giving nitroglycerin. And number 4, watch out for cardiogenic shock, arrhythmias, or mechanical complications post-MI. All right, let's get some practice in. Question 1. A 58-year-old man with hypertension and diabetes presents with 30 minutes of crushing chest pain radiating to his jaw. His electrocardiogram shows ST segment elevations in leads 2, 3, and AVF. Troponin result is not available yet. Which of the following is the most likely diagnosis? Is it A, non-ST elevation MI, B, ST elevation MI, C, unstable angina, or D, vasospastic angina? I'll give you a couple of seconds. If you chose B, ST elevation MI, you are correct. ST elevations in leads 2, 3, and AVF indicate an inferior STEMI, likely due to right coronary artery occlusion. NSTEMI, or non-ST elevation MI, and unstable angina do not have ST elevations. And vasospastic angina usually presents with transient ST elevations. Question 2. A 63-year-old woman presents with substernal chest pain for 45 minutes. Electrocardiogram shows ST elevations in leads V1 to V4. Percutaneous coronary intervention is unavailable at your facility, and transfer will take 3 hours. Which of the following is the next best step? Is it A, give IV heparin and transfer, B, administer fibrinolytics, C, start metoprolol and aspirin, or D, perform immediate coronary bypass surgery? If you chose B, administer fibrinolytics, you are correct. If PCI cannot be performed within 120 minutes, fibrinolytic therapy should be given ASAP. Great job! And that wraps up our discussion on STEMI. Remember, early recognition and rapid intervention saves lives. If you suspect a STEMI and see that ST elevation on your electrocardiogram, activate the cath lab ASAP. Thanks for tuning in to the ProPA podcast. Don't forget to subscribe and stay updated for more episodes covering cardiovascular topics. And as always, this is the ProPA podcast, where future pros in medicine are made. See you next time.